Apologies if there's a little murmuring in the background, it's my puppy dog. So Hannah has raised an incredible £1,560 to improve the clinical environment and care offered to women attending the emergency department who have experienced pregnancy loss or threatened loss. An incredibly important issue. Hannah's vision is to create a dedicated room for these women that is less clinical in its feel, and to improve the equipment and lighting required for examination, and the money raised will go towards this, as well as providing care and comfort packs to women. Hannah has already started sorting and providing these packs. They've been very well received by patients and their families so far. I must congratulate Hannah in her mission to improve care and experience for women going through these traumatic experiences while attending ED. She demonstrates compassion and excellence in going above and beyond what is expected to improve care. Hannah is an incredible nurse who holds all the essential qualities of a nurse and always strives to meet the trust, mission and vision, and is an excellent role model and leader in ED. I would like to see Hannah recognised for incredible work. As a board, we were talking about public service this morning, and I can't think of a better demonstration of that by Hannah. So Hannah, although you're not with us, a big round of applause. And then
Hannah's with us, Chairman.
She's just not herself, Chairman.
Oh, sorry, that's me getting confused. Hannah, that is brilliant. I was told you weren't going to be with us, so that is totally
yes, I'm here.
Hannah, thank you so much. Honestly, that is an extraordinary piece of, application of stuff that you don't need to do, but makes all the difference to those families. So thank you very, very much.
No problem. Thank you very much.
Okay, and if there's a sort of a Just Giving page or something that you're raising money to, or we can contribute to, can you just let Erica know, and then she can circulate to the board, and I'll try and raise a few more quick for you.
Oh, lovely. Thank you very much.
Okay,
very much appreciated.
No, thank you. So the second award is the Team of the Month award, the GAU Medical Nursing Team, which was nominated by Felicity. I'm not sure if we've got Felicity anymore on the line, but Gloria, it's lovely to see you, if it's just you.
Yes, I'm here, and also I think Lindsay, Ward's sister, is on here as well.
Okay, hi Lindsay. So just to read out the nomination from Felicity. This team only started working together in December 21, when GAU became the COVID cohort ward. Initially, staff were unhappy about being moved from their base wards to support GAU. Many did not have a choice and were told from managers they were moving for 8 to 12 weeks. Sister Lindsay Brown has been pivotal in ensuring patients receive the care that they need and that staff feel welcomed and supported. It has turned out to be a positive experience for all, and staff have really gelled together to work as a team. It takes a special kind of nurse to care for COVID patients, and without these staff, GAU would not have functioned as well as it did. Their robust attitude and work ethic has made it possible. These staff have been through a tough journey, but they've stepped up and got on with it. The trust care values were evident in the way they cared for these vulnerable patients. I'm very proud to have these nurses as part of my team. So everyone on the Gilwell Ward, thank you so much. Gloria, Lindsay, Felicity, everyone, fantastic. A big round of applause from the board.
Thank you. Thank you.
And keep up the great work. Lovely to see you. You're all very welcome to carry on joining us for the rest of the board. But equally, I'll understand if you want to disappear and do something else. So this morning we've had a busy morning.
I'm going to disappear.
Okay, Gloria, you disappear and take care.
Thank you.
Yeah, thank you. I'm going to run back to A&E.
Okay, thanks, Hannah.
Thank you very much.
You take care. Can I ask everyone to go on to mute? Welcome everyone. We've had a busy morning already as a board. We had an interesting patient or sort of team story about some of our frontline teams working in paediatrics. We then had a session on the Mental Health Act and Mental Capacity Act and our responsibilities as a board in that regard. And then we had an important session on the productivity transformation work, which is fantastic stuff under John Barnes and Andy's leadership, which is going on behind the scenes. But as we come into the board, we are, as the board papers indicated, certainly facing into a very challenging period for the Trust and the NHS generally. And I can assure members of the public that as a board and the executive directors in particular are very focused on doing what needs to be done to make sure that we provide the best service to our citizens and focus on the biggest prizes first of all. So I think I've only got apologies from Lucy, and so it's welcome again to Emma, who's standing in for Lucy. And then I think we've got David Whiteman on the board meeting as well. So David, if you're with us, welcome. My MS Teams isn't working properly at the moment, so I apologise, I can't see everyone. And David is on the ICB board member. So any new declarations of interest, team? Please raise a digital hand. Actually, just to make sure my digital hands are working, because my MS Teams is proving problematic. Glenn, could you raise your digital hand just to make sure? Okay, fine. So they are working, thank you. So no new declarations of interest. The last set of minutes, was everyone happy with the accuracy of the last set of minutes? If not, please raise a digital hand. Okay, can't see any digital hands raised, so I'll take those as an accurate record. So we'll then go on to matters arising and the action update, which is on page 18 of the pack. And the first is regard to the integrated performance report. The first was feedback on the new style integrated performance report to be provided to Jane. That was done. Thank you for that, and it's great to see the lovely photographs of everyone. A bit disappointed, Glenn, we haven't got a photograph of you on the Chief Executive's report, but I'm sure in months to come we can address that. The second was that the Associate Chief Nurse Medical Division will ask Lucy to provide an update on the issue around the delays in initial health assessment being carried out due to demand. And then the comment is a deep dive into this matter was discussed at the Quality Committee at the end of July. Chris, are you happy with that?
Absolutely, thank you. Yeah, very much so. Yeah, thank you. With the, I will be raising it a bit later, but that's fine. Thank you. Super,
thank you, Chris. And then Jeffrey will review the KPIs and the time frame after recruitment of staff commence in post. Jeffrey, do you just want to quickly pick up on this?
Oh, thanks, Chair. Just to add to that, we've also expressed an interest in participating in a national pilot looking at recruitment timelines, protocols, and structures. So we will find out by mid-September if we've been successful. And if we are successful, we're going to be part of this pilot for maybe 6 to 12 months. So for now, we've reviewed those timelines, but those could change if we undertake the pilot program as well.
Okay, keep us briefed on that, Jeffrey. Thank you. Sounds like potentially exciting stuff. And then on Freedom to Speak Up, a couple to come to the future. Freedom to Speak Up will contain an update on the numbers of staff receiving feedback following raising issues. We'll do that in October. Look forward to that. And then Katie will review the breakdown of the reasons for the use of healthcare assistance agency staff. Katie, we touched on this a little bit this morning, but what's your update on this?
Thank you, Chair. So I'd gone back to the notes from last time as well. So this followed a query from Glenn in terms of the higher level of agency staff that we'd seen in that healthcare support worker group, and the query was around how much were we covering by bank as opposed to relying on agency. And so we know that we've seen a much higher use of agency staff for healthcare support workers over recent months with some of our workforce challenges, and some of our actions through our nurse agency reduction programme are looking to tackle that. Wherever possible, we look to cover gaps through bank. So as an example, in July, we had 913 shifts that we filled through bank as opposed to agency. So by and large, we aim to use bank wherever we can, as that's a lower cost and preferable solution. Many of these are our own staff doing extra shifts. Primarily reasons will be vacancies and sickness above expected levels. And Emma has the safe staffing report later on the agenda today, which will touch on some of those issues, and Jeffrey through the workforce and OD strategy update again. So there's a theme that runs through all of the papers today, but it is an area where we're seeking to reduce agency use.
Okay, thank you, Katie. Any matters rising that I've missed? Okay, team, so we'll move on then to Glenn's update. Glenn, over to you.
Thank you, Chairman. So I'm going to talk through a few highlights from the report. Firstly, I talk about the winter plan, as I refer to, although its full title is included in the section there. It's the earliest I can remember, which probably means the earliest on record, bearing in mind the number of winters I've gone through, that we've had a winter plan published, which is a good thing to have it early, but also it signals the concern that many have about what we will be facing this winter. As well as obviously the ongoing risk of COVID, there's lockdown over the last couple of winters has suppressed quite a lot of respiratory illness that could come back with a bit of a vengeance for all age groups over the coming year, as well as we're already operating at occupancy levels that are winter-esque, and we're just in September. So this plan sets out a number of things that are being done to tackle that, and an assurance framework that will be firstly populated by integrated care boards, but then also will have some accountabilities for organisations like ours, which I think is a really important component of that. And obviously the governance that we have as an NHS trust will deliver on the things that are within our remit to deliver on. But I think we probably do need to take a much wider view over this winter about some of the things we can seek to influence. That national plan sets out additional funding to support 7,000 beds or bed equivalents. And by bed equivalents, we mean things that are done in the pathway of care, of urgent care, that have an impact to reduce bed related demand. And certainly those kind of things are much better than beds, actually, because often beds just result in patients being inappropriately held in acute settings. And we'll be doing our fair share of those, and they will need to deliver. And one of the things that the national team will be looking at is tracking all of those additional beds and making sure they're in place and that they're being used effectively. I set out some of the things that are within that document, some of the core objectives that have been set out, including the 100-day challenge, which we're getting towards the end of now, which by the time we get to the end of this month, we'll hopefully have implemented some changes that will then remain for the rest of the winter and will help us to ensure effective discharge. But I think it's also fair to say that the things that are listed there are not going to be enough. So throughout yesterday, I spent some time with the national team talking through some of the other things that we need to give consideration to, and there's some more work going on that now. I think from our perspective, I just pull out, if I may, Chairman, just 6 things from that I think are really important. Firstly, just making sure that we do the things that we know work, and doing them well, and doing them all the time, and having that assurance that they're being done. Secondly, I think we need to take a different approach to risk over this winter. Clinicians are really good at considering the risk of the individual patient in front of them, but we need to now consider whole system risk. And the best example of this would be patients who are in an acute bed and could be cared for at home, whilst at the front door of the hospital we have patients waiting in ambulances for treatment. And so we need to get people into that kind of wider risk thinking. We need to take a close look at care homes and develop really close relationships with them. And ideally for me, making sure that all care homes are enabled as if they are virtual wards, so that those patients get support where they are rather than being conveyed to hospital unnecessarily. We need to get back into a COVID incident footing. We're not going to get back into a level 4 national incident unless something else happens. But we need that permissiveness of mindset that says we're going to try some things and do things and move rapidly to make those decisions. We need to support our workforce is probably the most important thing within this, and we'll be giving further consideration as a team to how we can provide that support, but also what we can do to improve recruitment and retention. And we need to take a really close interest and be really supportive with our partners in social care. The pressures that are particularly around domiciliary care, but also around care homes, are going to be with us throughout this winter. The impact of fuel poverty, not only in our community, but also in some of our care homes that could actually tip some of them over the edge. So we're going to get really close to them. Elsewhere in the group, we'll be doing some work at looking at what we can do to get involved in the domiciliary care market, and if that proves to be effective, then we'll bring that learning into Wye Valley also. I then talk about the August 3 boards meeting, which is the first time we did that. We did that in a private board meeting for the first time because it was a bit of a trial run, and I'm glad we did because we needed to sort out one or two things within that. But it was a really good meeting, and future meetings will be in public. And we've now moved to that integrated performance report that we've already referred to in the course of this meeting, and that helps us to compare and contrast performance and see where the good practice is across the group. We also looked through at some of the financial implications of COVID, and particularly some of the business cases in all parts of the group that we've implemented over the last couple of years that have not necessarily delivered the numbers that we needed them to, for understandable reasons. But we need to get back to what we set out to do and to evaluate those cases against that. I then go on in the report to talk about reducing temporary labour costs, because we gave that some attention in the board meeting. It's particularly concerning for Wye Valley, and the headline 16.5% of our pay budget is obviously an indication of not great use of finances, but probably more importantly, agency staff not necessarily being the best deliverers of care to our patients, not because there's anything wrong with them, but because they're not familiar with our system, and the best thing is to have substantive staff. So we are doing a lot to address this. The medical agency review group and the nursing agency review group are back up and running, and our project lead on this has got a really good approach to it, and I'm sure that will help us to get improvements in both quality and our financial performance. And I also just note that when we look at business cases in the future, we clearly need to consider whether plain cost of staff is an appropriate thing to test the finances against. We probably need to look at premium costs, and then we might make some different choices. And then I go into some detail on the medical division. I won't go through all of it. We discussed some of the productivity indicators earlier today. One that's been really useful is this summary acute provider indicator table, which shows a whole range of indicators around urgent care, and shows some things we're doing really well, but also some opportunities where we could improve, and we'll be working our way through that in the course of the next few weeks. Over on the next page there, gastroenterology, there, my IBD app is a really good example actually of something that through investing in technology, we can reduce hospital associated demand, and we look forward to that making the impact, and also making an impact on our carbon footprint, which is something we're really keen to do also. And then it's also great to see in the recruitment section, particularly the fact that we've got two new geriatric consultants, one of them who's already started with us, because that's an increasing area of demand for us, and one that we need to make some further improvements in. Plus, I won't go through all the others in that list. And then finally, the Going the Extra Mile award winners that we just heralded. So that's all I wanted to go through, Chairman, if that's okay.
That's great, Glenn. Very comprehensive, and great that you're involved in the sort of national discussions, but also the sort of clarity of thinking about what it means for us as we enter the winter. Any questions or perspectives, or do colleagues want to get into the IPR? Nicola?
Oh, yeah, it was only a quick one, and it might be for you or it might be for Jane actually, but we talk a lot about our relationships with care homes. We know that's got to work for everything else to work, and I just wondered that, how's it going? What does it feel like in Herefordshire? Have we got any examples now of what good looks like? Because we talk about it, I'm not always sure that we hear examples of where it isn't working and what that actually means. So that I just think that would be interesting, especially as we go down this journey to tell those stories.
Yeah, I think one thing that springs to mind with me is when we had one of the care homes talk to us about the impact of COVID actually a little while ago, and they felt abandoned by the NHS during that point. So I think over this winter, with everything that's going on, we need to be really, really close to each other and support them and in-reach services. Jane might be able to talk about some specifics on that, but I think the way that we've been working in place is very much having that direct dialogue with partners and feeling all part of one system and not having any kind of blame game, because they're really important partners. Jane, is there anything you wanted to add on that?
Yeah, I guess the bit I'd add, and actually Francis might know a bit more than me, it's the so we do have a programme called Enhanced Health in Care Homes, where we've sort of got an integrated team across GP, social care, and our teams who are supporting the staff, particularly in care homes. So that's a project that's or a programme of work that's under ICE, and so I don't know, Francis, if you wanted to say a bit more about it.
Yeah, absolutely. I was going to say that it is exactly that, joined up. And I think, well, thankfully, we've moved beyond the days where health and care staff didn't go into care homes because they'd already got them. So it is this. And as Glenn said, how do we keep people in their own bed where that is possible? And for people who live in a care home, that is their own bed. So it's providing that support to enable that, and really joined up with general practice so that we have a single assessment, care and support plan, and use all of our teams as wisely as we can. One of the things that is very good is there is a very robust and cohesive care home group that's been led by the local authority and by Nisha Sankey, who's the Director of Primary Care Networks for general practice. And so they've been working together to support and kind of troubleshooting, you know, and saying we're all in this together. So I think we're starting from a strong base in Herefordshire, but there is a lot more we can do.
Okay, thanks Francis, thanks Jane, thanks Glenn. I think we shouldn't underestimate though the challenges care homes are currently facing. There's an interesting piece on the BBC yesterday interviewing some care home operators saying that with the increase in energy costs, their situation was becoming desperate. Need to pick up the pace a bit, guys, but Grace?
Thank you, Chair. Thank you for the great report, Glenn. It's great to hear about the My Inflammatory Bowel Disease app, and it sounds like it's brilliant savings on patient time and money and carbon. I'm just wondering, how are we logging these savings and seeing where perhaps we get the data this practice might be able to be expanded?
Great question, because I think there's quite a lot of innovation going on that we don't necessarily capture as part of our explanation of our CPIP program. So obviously we're channeling that through a lot of the improvement work that we're doing. Jane, do you want to talk about the specific measurement on that?
Yeah, we've started, it's its second meeting now, transformation board, where we're trying to pull all of this stuff together, and that is one of the things, is to look at, to make sure we understand what some of the financial implications are as well. So it's relatively new, but we are trying to track all of those improvements as well. We also, for particularly where there's a business case that we've supported, we do have a process to bring it back through trust management board and say, did it deliver what we wanted it to deliver? Now, we lost traction a bit on that over COVID, but again, we've just reinstated all of that again. So we're bringing back those business cases to make sure we're getting what we thought we were going to get from them. And
thank you. And Richard?
Yes, I just wanted to express my disappointment, Russell, at the quality of the national guidance in relation to the winter plan. This was a real opportunity for NHS England, not simply to acknowledge the scale of the challenges that we face, but to offer some practical, sensible support on how we prioritise the inevitably hard choices that will come at us as we get into winter. Instead, we get this almost ridiculous list of targets, which appear to have been written by somebody that's been locked in a dungeon for the last 2 years, because we now have things called integrated care systems that are supposed to focus not just on acute hospital performance, but how well the system works together to reduce the need for healthcare and social care in the first place. So I think it's a real missed opportunity and a real failure of national leadership, actually. And thank goodness, and this is the positive bit, and then I'll get off my soapbox. Thank goodness we have strong local leadership and partnerships that will enable us to find our own solutions to some of these things, because we're certainly not going to find them from above. Thank you.
No, Richard, duly noted, and thank you. And I think the key takeout is we can't allow ourselves to become the victims of others' decision making. We need to do what we need to do, and we know the right decisions to maximise performance for the citizens of Herefordshire. Colleagues, happy to move on? Thanks, Glenn. So we'll move on then to the Integrated Performance Report, and a smiling Jane. Jane, over to you.
Always smiling. So we are pretty much in post-COVID now, and of course we may get another wave that comes again at winter along with those other respiratory diseases that Glenn was talking about. But we are pretty much in post-COVID at the moment. So I think we're down to 7 patients today. There's national guidance came out last week, which was around only testing both patients and staff who are symptomatic. And so that's quite a big change to the way that we'll be working, and that should help a bit and will ease up some of those bed pressures a little bit. So now we may go back into a COVID world again, but that's quite an important change. One of the things that we had to do along with other people, but I think we probably did it for a bit too long, was around visiting restrictions because of COVID. And whilst we have opened up again, we're still a bit more restricted than we used to be. So Lucy with her senior nursing colleagues are looking at that whilst Lucy's on holiday, and then seeking to change that and actually go much further than we used to be. I think we've always been a bit too tight on visiting restrictions. Because I think when we look at that wider aspect of patient experience, we know that that had a really significant impact on patients and staff, actually, of not being able to have visitors over COVID. But also things like our falls rate. You know, if we've got someone's relative sitting next to them for a large part of the day, we've got eyes there which we wouldn't have otherwise. So I think there's a safety benefit in that as well. So looking to really extend the amount of visiting that we allow more than we did previously. So that's one part of patient experience. The other part, which I mean Glenn's alluded to, is around urgent care. So whilst we have done really well, and Andy can probably talk in more detail about it in terms of prioritising those things that are going to keep people safer, which are 2 things really. One is making sure that we release ambulances quickly so that they are available to go and pick up the next 999 call. And the second is, once patients get into ED, the time to treatment. We do very well on both those benchmarks, but we do very poorly on the amount of time that patients spend in ED before they get to bed. So, you know, this morning there were 2 patients who spent more than 24 hours in our ED because there isn't a bed available for them. And the balance on this is extremely difficult, isn't it? Because at the same time of trying to ring fence our elective capacity, because those patients who they may well be waiting for a planned surgery, but often they're in pain and often they are at risk of other things happening to them whilst they're waiting for their operation, so that it's not risk-free to leave patients waiting for a long time. So it's really important to ring fence that, but at the same time try and use our beds so that we can make sure that we discharge patients out of ED effectively as well. And so we are seeing many patients in ED at the beginning of every day who've been waiting overnight for a bed, and then during the course of the day generally that will happen. So as Glenn said, seeing that sort of situation, which generally we wouldn't have, we'd be seeing that for a few weeks in January normally. Seeing that happening every day in July and August is really very extremely worrying for winter. So it's a whole range of things that we're doing. And again, Andy can talk through some of the detail of that. But I do worry, as Glenn says, that the die is sort of already cast. The workforce challenges that we have aren't going to suddenly get better over the next couple of 3 months, and so I think we are going to have to make some difficult choices over the next few months, and it's important that we get our clinicians to be leading that discussion, and we do the best that we can with what we have. So yeah, some hard choices coming, I think. Actually, over while we had the break between our workshop and board, actually I went and spoke to the cabinet of the Herefordshire Council along the same theme, really. So important point that you make, Glenn, around that being joined up with the local authority, so them really being on the same page, understanding the wider system, and they very much want to play their part in making sure that they do what they can to create that community capacity. But again, this isn't easy. That workforce isn't available to us. So I say difficult winter ahead, I think. So elective wise, we're doing relatively well. We're doing what we said we'd do. We have no 104-week waits. We're moving well with patients, nobody waiting over 78 weeks by the time we get to March, winter aside. So the other issue, I guess, is really occupying a lot of our attention is recruitment and retention. So on the recruitment side, we do relatively well on recruitment, actually. It's retention where we're really worried. I mean, we're up to 14.5% turnover. We haven't seen numbers like that for a very long time in Herefordshire, and we've seen, when you look at the graph, it's just gone, every month it's gone a little bit further adrift. So a lot of work that Jeffrey's leading on, and we're all supporting with about what is it that we can do to support retention, and it is going to be about supporting our staff, but we may well have to do some things around pay as well, I think, because we are in a competitive market with a cost of living difficulties that we've all seen coming up, and so we may have to do some things on pay, and there will be a proposal that comes back to board next month, particularly around our Band 2 workforce, and some thinking that we've got around how we might retain those staff better. So all the really important things that we need to do around making sure that staff are supported, secure, helped, listened to, working in a good team, all that stuff's very important. But it might not be quite not be enough. So 4 priorities, which I sort of talked about last month, really, and really it's the message across the whole organisation. Is we have 4 priorities really for the rest of this year: emergency flow, including our partners, recruitment and retention, productivity, and then improving the experience of our patients. That those are really the 4 key things that we'll be concentrating on as we go through the rest of the year.
Jane, very clear, very comprehensive, and 4 of the absolute right priorities. And thank you for the big dose of realism in your narrative. We have got a lot of ground to cover, guys, so if we can try and speed up, that would be great. Frank, questions and perspectives?
Yeah, thank you. Staff retention. Nicola and I were in a meeting the other day, and we heard of at least 2 staff who've left because their partners couldn't get jobs. I sit on board meetings elsewhere where I'm repeatedly told that people are struggling to find labour, and I just don't feel we're joining it up enough. And we could be almost putting a recruitment agency approach in place for the spouses or the partners of our staff. I've said this before, and I've got to keep saying it until I feel we're dealing with it. And the first 100 days is crucial in trying to retain staff. And I've suggested, and to be fair, Lucy's received it well, that we as NEDs in our walkarounds could spend time in the first 100 days with people to find out what it is that makes them want to settle. Thank you.
Yeah, I'd agree, and we're aware, Frank, of those two cases. In fact, I did go and talk to the ward manager, and it was too late by the time the member of staff had said to her, "Actually, we're going because my husband's got a job." It was a hospital-based job. Actually, it was EBME engineer, and we could have done something about that, but it was too late. So it's about every aspect of this, isn't it? Of managers really understanding their staff, where they are, what their needs are, is everything okay in the rest of their lives. So a lot of this is really good management and really good leadership, right through the organisation.
And too late says exactly that, doesn't it? Too late says we should have known sooner, and if we'd have engaged in a different way, we would have known sooner.
Yeah, I think that's a fair point, Frank. We need to make sure we don't score own goals on this type of thing. So thank you, Frank. Thank you, Jane. And then we're up for quality. Lovely picture in the pack here of David Mowbray looking as though he's on a clothing catalogue maybe, or a dating site photograph. And Lucy, who's being covered by Emma today. So David and Emma, quality please.
Thank you. Yeah, there's just a couple of elements really I want to pull out of the report. So the first is just to let the board know that there is a new patient safety and incident reporting framework now that's recently been published, and we've got 12 months to now implement that framework. It actually replaces what we've currently got in place as our serious incident framework. So there will be a number of changes, and there is a plan to undertake a board workshop in December of this year to be able to present in more detail regarding that new framework. I think the other thing that I was wanting to pull out, Jane's already alluded to, which related to the new guidance for swabbing and also cohorting contact patients on wards, which will be a real positive, I think, moving forward. A few elements that Lucy has included in her reports regarding falls, complaints, but I really wanted to focus on the same-sex breaches. We've seen a real increase in July, and we are an outlier against our counterparts for the numbers of mixed-sex breaches that we've been occurring really within our ward areas. A number of reasons for that. Some of it is COVID outbreaks. So Frome have seen an increase, and that's because we've had to cohort contact patients together within that ward area. And day case has also seen an increase in July, and that's where we've had medical outlying patients that again have needed to be cohorted together. So we've been able to use the other side of day case for our elective activity. We've also had some breaches in our elective wards as well, and for the same reasons, ensuring that we can actually bed those patients and not cancel operations because of not being allowed to mix sex breach. So it's something we're very aware of, and we are trying to bring down. And I think some of the new infection prevention and control measures that are being put in place should support us with that. So that's it really from me, but I didn't know if David wanted to pull out anything regarding mortality.
David.
Yeah, thanks, Emma. Yeah, so the position is we're still high but stable, Russell. The latest actual figures are, as we suggest there for ourselves, to put it into context, our Worcester colleagues' shimmy is 109. Swift's is 107 and George Elliott's is 114. So everyone's seen a rise in these figures. So it is still a little bit of an enigma. We are, however, starting to tease out where we think things are going wrong. So in the slide on the left there, I've included something called the RAMI, the Risk Adjusted Mortality Index, which I think Swift definitely used. This is the figures taking coding away from the issue. So you can see we're sort of middle of the pack there, still a little bit above average, but nowhere near where our current shimmy would be putting us. As I've mentioned before, the issue is out of hospital shimmy. And there's various reasons that might be the case, some of which are the way we code our patients, some of which may indeed be clinical, and that's what we're auditing as we speak. So I had a meeting with the teams that are responsible for the 30-day mortality figures, which is, I mean, predictably acute medicine and frailty, and we're going to take a sample of those patients and see if there's anything that actually stands out as an issue. We will then go through that with the coders and see if the coding representation of those patients aligns to the clinical representation of those patients. So that's a work in progress, and I think that's probably all I want to say, Russell.
No, thank you, David. And keep us briefed on that as you continue to unbuild the analytical onion. Any questions or perspectives to Emma or David? I can't unfortunately see anything. I can't see the chat box, so apologies, colleagues, if things are going in the chat box. I cannot see it. Andrew?
Yeah, I just wanted to pick up on complaints. When we discussed it in the workshop, I think we agreed that we would keep the time taken to resolve the complaint. And we would hope to see the new measures automatically bring that down or improve that, take it up. And I was just wondering when we might expect to see that, because if you look at page 52, I think it is, you still see there's not really an improvement in the time taken to resolve complaints.
Jane, do you want to comment on that in terms of what you'd expect to see the sort of improvement trajectory to look like?
Yeah, I'll take that away, Andrew, and talk to Lucy.
Okay, come back on that. Thank you. Emma, did you want to come in?
Just really to add, certainly within the surgical division, we've been doing an awful lot of work around complaints. I think part of the organisational problem probably sat really within surgery. We had a large backlog of complaints that hadn't been answered in a timely way. We were up to around about 58 complaints outstanding, and over 30 of them were overdue. So we've been doing an enormous piece of work really over June and July to bring that down. And as a division, we're now down into the 30s for complaints to be responded to. So I would imagine that would start to have an impact on us being able to answer complaints in a more timely way. And I know certainly medicine didn't have the same issue with backlogs that we did. I'm not sure about community services, but I think, like I said, a lot of that problem did lie within surgery and is being resolved.
Okay, thanks, Emma, and thanks for the briefing. But Jane, if we can minute it and you come back with the full picture, that would be great. Frank?
Yeah, can I just go to falls on page 27? Everything I read to me just seems like another expression of everything I've heard many, many times before. And I don't sense we're doing anything different. The root cause of any fall is movement. There's technological innovation out there that works on movement and changes things. Burglar alarms comes to mind. We don't seem to be doing anything new in handling falls other than talking about them, and I think we should be looking at innovation. Thank you.
Thanks, Frank. Emma?
Yeah, I'm not an expert in relation to the technology, but I know that Joe Burns within our physiotherapy team has very much looked at devices that have been available. We have trialled some in the past, but I think I don't think they've been particularly effective in relation to preventing falls. Joe would be able to give us far more information. I think part of our issue at the moment is regarding our HCA workforce, and we're working across many areas with gaps within our HCA provision at the moment. As we've already discussed today, I think the visiting would have a really positive impact on that, as again we've alluded to, having the relatives to be able to support with that. We're not an outlier for falls, which is a positive, certainly for harm with falls as well. But it's absolutely something that's in our radar, and any fall is an issue. We don't want anybody to fall within our care, and the impact emotionally as well as physically it can have on patients is massive, for a loss of confidence, and obviously it can cause physical harm as well. So it is something we're really mindful of, but I will take that away and look, because it is a few years since we've looked at any devices, so absolutely take that away and speak with Joe Burns about it.
Okay, that's great. I think things are in the chat box from David about some of the technology. Glenn, did you want to come in on that?
Yeah, just to respond to Frank. I mean, yeah, the technology. I think there is some good technology there now that we can use on this, both in healthcare settings, but also supporting patients at home or in care homes. So we need to keep looking at it. As Emma said, it gets better all the time. So so we need to be ready to embrace that, because we certainly won't be able to magic up the workforce to do it in the old way.
No, I think that's absolutely the right point, Glenn. Even if the technology is not perfect now, at some point it will be. And finally, Grace, then we need to pick up the pace.
Thank you, Chair. Two very brief points. Firstly, in terms of patient complaints and around with this touch on patient experience, I'm aware from other meetings that quite often communicating with your doctor and understanding your treatment plan seems to come up as a big communication issue that we seem to still keep talking about. I'm just wondering, is there any guide or help or support to understand what that is? I mean, do we have a breakdown of what the issues are within communication, what aspect of treatment plan isn't understood, and can we meet that elsewhere? For example, a guide to how to understand your treatment plan, or what you might need to be able to process that. My first point. My second point was very briefly, absolutely falls innovation. CAMRA, the Centre for Movement Analysis in Bristol, are doing some good work. I think the innovation does come on very quickly, and there's also a pilot I read of in the Netherlands where they train people to fall well, so that they would fall, but would fall without having serious injuries. So I'd love a session on best practice for falls as well. Thank you.
Okay, take that last point away if we can. Emma, did you want to come in on the first point on, if you like, communication?
Yeah, we have done some trials across some of our ward areas regarding booklets for patients where the sisters actually go and sit with the patients following ward rounds so that they understand what's been said, understand about their discharge plan. And we've certainly seen within those areas a decrease in complaints regarding communication, which is positive. But I think the majority of complaints that we're getting that relate to communication and treatment plans are regarding outpatient appointments. So there's definitely some work we need to take away, Grace, and look at there across the divisions to see what we can do to support.
Yeah. Okay, team. We are running quite a long way behind now, so I'm going to ask the executive directors to really pull out the key points that they want out of their paper. So, Andy, do you want to brief us on activity?
Yeah, thank you, Russell. I'll be succinct. I won't dwell on urgent care pathway, etc. That Jane has picked up on that in her report, and Glenn is picked up on this single acute provider indicator tables, but it's there in my executive narrative. Just two areas really. One is cancer remains a challenge. We are seeing a number of pathways with 100% increase in referral demand compared to 1920. Our 28-day standard is nowhere near where we want it to be, and should start to see a significant improvement over the next 6 weeks as we start to implement, particularly in a skin cancer, rapid access clinic for lesions. Our 62-day standard also remains a concern, although we remain 10% above the average for our comparative peers. We are seeing a reduction in our 104-day wait, so we've reduced over the last 6 weeks from over 40 down to 20, and that means a key focus for us. Some of the key areas that we need to focus on are colon CTs and that capacity, and we've increased our CT capacity in September through increased mutual aid and some insourcing, which starts at the end of this week. Our endoscopy capacity is also a concern, although we are seeing some improvements there with session take up, and we've reduced our waiting list for our cancer patients from 4 weeks to 2.5 weeks over the summer period. And our team remain focused to reduce our 62-day breaches to 1920 levels by the end of this financial year. Moving on to elective activity, our new and follow-up activity remains ahead of 1920, and our elective inpatients over the last 6 weeks have increased and are ahead of 1920's activity and ahead of plan for this year, which is a positive sign of our improvements. Yet our day case activity is still driving the reduction in our plan and compared to 1920. The board heard this morning about our productivity plans, and obviously that's key. To improving some of our productivity plans, and also the implementation of our productivity board to ensure we've got the governance and assurance wrapped around that. But we are seeing a reduction in our 78-week breaches, and they continue to reduce week on week, and our cohort that breached 78 weeks by the end of March are also reducing. So it's reduced up by 1,000 patients in the last 6 weeks to 1,700 patients that we need to treat that won't breach the 78 weeks by the end of March. Thank you, Russell.
Andy, thank you, and thanks for your succinctness. Just before I ask if there's any other questions, Andy, how are things going with our friends in Worcester, things like haematology? Is all of that sort of working well? We still got challenges?
We still have some challenges, Russell. So we still have some challenges on our own workforce. So unfortunately, we lost a locum recently, but David is currently courting additional locums to backfill there. We've still got some hurdles to get over with our colleagues, both in Worcestershire and Gloucestershire. And there's actually a clinical meeting occurring this evening to work some of that through for the short and medium term.
Okay, great. And in terms of discharges, I know we've had some particular problems more recently with Powys, but is any of that getting easier to relieve the, if you like, the constipation of medically fit for discharge?
Still remains a challenge, not as significant as it was during the period towards the end of July and beginning of August, but inevitably the bank holiday weekend has caused some issues, but we continue to work daily with partners and colleagues across the system to improve flow, but still remains a challenge.
Okay, thanks, Andy. Andrew?
Yeah, just following up on your comments about elective activity, day case and inpatients, the year-to-date performance, there's quite a significant, we're quite significantly below target. And that's obviously having knock-on effects to the waiting list, but also there's a financial risk associated with it, if my reading of the paper is correct. So I suppose, given that the last few weeks you've seen a big improvement in the elective inpatient side, what do you think the prospect is of us meeting the target over the 12 months?
Andy?
So, Katie may want to comment on the financial element of the ERF monies, but in terms of our activity, I think we will struggle to catch up on the loss that we saw, particularly in the first 8 to 10 weeks of the year. Although what I am confident of is once with all the pressures of winter coming up aside, in terms of the plans that we've got in place and the productivity plans we've got in place, I'm confident that we will recover our plan to date in terms of the week-on-week plan, but we won't recover the activity we lost at the beginning part of the year.
Okay, thanks for your straightforwardness. And Katie, can you pick up on the ERF issue that Andrew referred to? And Ian?
Yes, thank you, Russell. Thank you, Andy. I just wanted to pause for a moment on the national comparative figures that there are in the report, the acute providers, and the fact we do relatively, in the midst of huge challenges, performing relatively well compared to others. And it's really in the context of this being a public board report for Herefordshire and Powys, and actually everything's dominated at the moment by the national news and narrative about the challenges to the NHS generally. And it's almost a general point that actually as a public board for Herefordshire, I think being able to pick out those points where actually we're doing well and indeed where we're not doing so well, because what people locally will want to know is actually what we are doing in Herefordshire. So in a sense, we kind of passed over it almost in passing, and actually I think it's worth emphasising that actually in those two areas, actually we are performing well in Herefordshire, notwithstanding that we face kind of all the challenges that everywhere else faces.
No, I think that point's well made, Ian. And I guess the balance is always that what we don't want to see for the whole system is a dubbing down of what the expected performance is. And it's why I think, for example, an 18-week RTT and 4-hour waits in A&D, it's important to remember that they are the standards we should strive for, given that they were in the NHS constitution. But your point is well made. Compared to others, we're doing in some ways pleasingly well, but we're ambitious, we're relentless in terms of improvement. So let's be ambitious, even if we are performing better than others in some regards. Okay, team, we'll move on then. Jeffrey, what would you like to pull out of your workforce narrative? And Jeffrey, I'm disappointed that there's not a photograph of you in the pack, given your sartorial elegance.
Well, thanks, Russell. I can guarantee you my photograph was initially in the pack. I'm not sure what's happened there, maybe some technological difficulties. But just going back to the workforce elements, I mean, Jane mentioned the significant challenges that we still face in terms of recruitment and retention. So we are taking steps to address that. We're expanding our international recruitment program. We're working with group and ICS-wide colleagues, looking at any additional steps that we can take to try and address the recruitment side. In terms of retention, we are launching a campaign, which we will call a call to action campaign, and that entails really working with all service managers over the next few weeks to really look at what else can we do to aid retention. So we want to make sure that we clear in terms of roles, responsibilities, expectations, and also just look at any other things that we can put in place to try and support our managers in terms of how we deal with retention. So we're certainly going to do some more work on retention over the next few weeks. We continue to work supportively with managers on our KPIs. And over the last few weeks, we've seen a reduction in sickness absence, but still a lot more work to be done. But we work with managers on that. And we continue to promote health and well-being because we know that's very important. And our Health and Wellbeing Week will run from the 3rd till the 7th of October, supported by a host of external partners. So much work taking place. And as Jane mentioned, we'll bring back in October a proposal on how we're going to be addressing the Band 2 staff issue that we've been talking about for the last few months. Those are the key highlights from my report, Russell. Happy to take any questions.
Thank you, Jeffrey. Any questions or perspectives to Jeffrey? Chris?
Thank you. You say in your summary, Jeffrey, that the recruitment and retention of Band 2s, Band 5s and doctors has continued to be a problem. I'd just like to point out that on Tuesday and Wednesday last week, when I looked at jobs available in Wye Valley, there was only one Band 5 advertised, and that was in paediatric surgery. And there was nothing about return to nursing practice. I do feel we really need to get a grip of this. There needs to be something plastered over the front of our websites, any social media. Tell us your skills. We may have a job for you. It has improved because I raised it with Lucy and she alerted colleagues, and there's been more jobs advertised since, but I was extremely disappointed, and I would encourage us to just keep on it. Thank you.
Thanks, Chris. I think that's just one to absorb, Jeffrey. And Frank?
Yeah, thanks. Sickness absence, again, a bit like the comment I made earlier, I feel I'm just reading the same thing. We're reviewing our sickness absence policy to ensure appropriate management actions are being implemented. I'm not sure what those management actions are. We never see any metrics that show us how we're doing on reviewing management actions. I presume it's referring to exit interviews, or sorry, return to work interviews. And I think we should start to measure something, because I don't feel confident that it's happening very well. Thank you.
Jeffrey, how can you make Frank feel more assured?
Well, what we do is at F&P meetings, we're going into more details on steps being taken to address sickness absence. And at the weekly COVID operational meetings, every week, we also look at sickness absence and look at initial actions that we have in place. Hence my point about over the last few weeks, we're now seeing a reduction in sickness absence. A lot of the sickness absence has been down to COVID and mental health conditions. As we're now seeing a reduction in COVID, we absolutely are also seeing a knock-on impact on the percentage of sickness absence. We've now gone down to about 5.2%, which normally at this time of the year, you would expect something in the region of between 4.5 and 5%. But as we've seen a reduction in COVID cases, that's also going down. But not just COVID, we also have actions that we implemented, and possibly at the F&P meetings might be the right forum for us to just expand a little bit more on some of those actions that we've taken.
Yeah, it's the management actions, not the reasons for sickness, that concern me. Yeah. To get confidence that the management actions are happening and we can see them improving things. Thank you.
There's Frank's grandfather clock going in the background. Time tolls for no man. But the point's well made, Frank. Thank you. And Nicola?
Yes, hi Jeffrey. I was just looking at some of the statistics, and my curiosity was sparked at Quality Committee last week, actually, looking at the appraisal data that we get all the time, and we never really talk about it, but I'm really conscious it's in decline, and it always shows that nearly a third of our teams aren't getting an appraisal on time. Now, there are lots of studies out there that show that a regular contact and a specific performance appraisal with your line manager is key with retention. And I don't think we always tie these things together. So I just say that when we pick up on retention, I would ask you to look at that. It's even proven that a bad appraisal is better than no appraisal within the retention process. So I think there's just some statistics. We see them, and I think sometimes we don't always get under the bonnet of what they are in a wider context. So just want to look at, I think.
No, good point, Nicola. I guess, Jeffrey, at the next round of F&Ps, I know we had F&Ps yesterday, but let's make sure we get under the bonnet a bit more and join the dots up. I don't want to dwell on it now, Jeffrey, but it would be good to hear in the future how our retire and return processes are being smoothed to help people who want to retire but do want to return. Based on lots of feedback I get, particularly from nurses, it's incredibly difficult with a lot of admin. And so not for now, but if you could brief us all on that, that would be great, because it's far easier to retain a colleague than it is to recruit a colleague, and it's far cheaper to retain someone on bank than it is to use agency. Okay, team, we'll move on then to the numbers. Over to you, Katie, and if you can pull out the RF point that Andrew referred to earlier, that would be great.
Yes, of course, Chair, absolutely fine. So this is the finance report for month 4. No picture for me either. I'm not sure where it's gone. It was there before, but maybe an opportunity for a new one. An apology to start with. So there are still references in here to a separate finance appendix, but this month we have removed that because the team reviewed the content within the new style IPR, and we're comfortable the key items are within here, and it will come through audit committee for a further review just to make sure there's nothing else that would be of value in the report. We have also now updated all of the tables to reflect the final financial plan of the 6.6 million deficit, because you'll recall at the last meeting there was that hadn't yet been reflected due to timing. So in terms of year to date, we've got a deficit of £2.4 million. That's marginally, so about 100k worse than we'd planned year to date. So whilst on the one hand that's quite pleasing that we're within a whisker of where we thought we would be, there does remain a significant level of financial risk over the coming months, so there isn't room to be complacent. Picking up the ERF point, so we've got within the position to date around £3.3 million worth of assumed income for the core ERF, so the 104% of activity element. The level of risk, you'll recall from previous months, was felt to be high, and that is reducing. We've been given endorsement to the fact that there won't be a clawback in the current periods, so the risk is lower as it stands today. However, we don't yet have full details of how the mechanism will work as we go through the remainder of the year, and particularly the second half of the year. So I think it would be prudent to assume there remains a risk. Andrew, to your point around the activity we haven't done from earlier in the year as we head into the latter half, but we're watching that closely and working hard with regional and national colleagues to get some certainty around that. But certainly the current assumption in the year to date reflects what they would have expected us to reflect regionally. In terms of areas of focus, so we've touched on them already through earlier sections. So agency spend remaining exceptionally high, and the actions that we've talked about. Cost savings delivery, so our risk adjusted delivery forecast is below where it needs to be, though there is still a focus on converting further opportunities, and we touched in some detail on that in yesterday's finance and performance meetings. Presently, we don't have a mitigation for the additional £1.5 million savings target that was included in the final financial plan, and that's phased in Q4, which adds to that risk over the coming months. But we continue to look for mitigations for that. And productivity, of course, remains a further key area of focus, as Andy's alluded to in his updates. Just briefly, in terms of capital and cash, so on capital, we've spent £1.7 million to date. That's primarily on schemes that were already in progress. And as we've said previously, we've got a really challenging funding level this year. So we're making sure we finish the things we'd already started. And in terms of cash, balances remain stable, and the no PO, no pay policy should help us to drive further improvement in our prompt payment to suppliers. Thanks, Chair.
Thank you, Katie. But I think the reality, Katie, as we look forward to the rest of the year is, as we get the agency costs under control, we're going to make our life incredibly difficult. Any questions or perspectives to Katie? Can't see any digital hands, so I'll take that as a no. Keep us brief, Katie, and thank you for your hard work. We'll move on then to the infection prevention annual report, Emma, which I think we can take as read because we see the data so frequently. Anything you'd particularly like to pull out?
No, like you said, the data's discussed frequently, isn't it, both in the key performance indicators and also through quality committee. So there's no new data. Just really to say about our clostridioid infections, as people are fully versed, we have been an outlier over the last couple of years, which has been a concern for us, and also a lot of external scrutiny due to that. We heard Laura's presentation at the last quality committee, where she said at the end of July this year we are on track for our trajectory for cases, so that's a positive that we're not exceeding our cases currently for this year. And the only other thing really to pull out, just to remind people, that we do have NHSI coming back for a third inspection on the 20th of this month, which we're currently preparing for at the moment. So hopefully we'll see how that inspection goes, but we're currently rated amber with NHSI, so we're hoping that will improve.
Okay, thank you, Emma. Any questions or perspectives on the annual report on infection and prevention? Everyone happy to approve it? If you're not happy to approve it, please raise a digital hand. Duly approved. Thank you, Emma. We'll then move on to the changes to the Wye Valley Board, which is on page 89, I think, of the pack. So by way of background, we are saying goodbye at this board to Chris and Richard after many years of phenomenal service to Wye Valley. And just before I move on, I just want to, not just on behalf of the board, who I know have found Chris and Richard incredibly helpful, supportive, value-added colleagues, but on behalf of the citizens of Herefordshire, I can assure you that Chris and Richard have been outstanding examples of NHS NED. So I want to thank you enormously for your personal commitment and effort over a number of years. You have been a pleasure to have as colleagues. But both Chris and Richard have informed me of their decision to retire. And so that leads to us being able to do a few things. The first is that Grace, Francis and Ian will now become full non-executive directors. So welcome to the NED nomenclature, whatever that means. But it also, in terms of subcommittees, means things of more substance. So Ian has kindly volunteered to step into the big shoes of Chris as chair of the Quality Committee, and that will commence from the 1st of October. Nicola and Andrew and I have agreed that Nicola will take over as chair of Audit Committee from the 1st of January, as Andrew's term of office comes to an end during the end of 2023, so we need to prepare for that. Andrew, though, in the meantime will become my deputy chair and the senior independent director when Richard stands down on the 1st of October. And John Barnes will become a voting executive director of the Wye Valley Trust Board. So a few sort of technical things, a few things of real substance. I know that Nicola in the case of Andrew, Ian in the case of Chris have got big shoes to fill. But Chris and Richard, thank you very, very much for your years of service. Any questions on those changes? Okay, lots of hands being clapped digitally towards you, Chris and Richard. So we'll move on then to the workforce and OD strategy update. Jeffrey, back with you.
Well, thanks, Russell. Well, the paper just outlines the quarterly summary of where we are at this current time in terms of the workforce and OD strategy. So I don't intend to go into any details because the paper is really for information and to provide the board with an update just to show the actions that we're doing behind the scenes, working with service managers on our workforce and OD strategy. So happy to take any questions. It's just to provide an overview of where we are at this current time.
Okay, thanks, Jeffrey. Jeffrey, I'll say something I've said before to you and other HR directors in the NHS. You have my immense sympathy in the number of priorities you get from the centre. It is disproportionately important as we enter this winter, as we are now, that you concentrate on the operational priorities to help Andy, Lucy, David and everyone else, and Jane in particular. So if there's anything we can do to take some of these, I think the phrase is monkeys off your back, which is that theory of monkeys, but take some of these things which load up on your back as things you have to do, just let us know because we're here to help you. But the operational priorities are the key things to focus on. Jane, just before I open it up, is there anything you'd like to add to that?
Yeah, it's two things really. One was I think the report really does show, Jeffrey, the sort of breadth of everything that's in your portfolio and the huge amount of work that's going on. So thank you for that. And also I think important to note that actually you've got a really capable deputy now in Daniela, which is a real support for you to go forward on these on all these fronts. But Russell's point is absolutely right, and I've made the same point at the ICS as well. We can't possibly do all the 104 priorities that are in the NHS People's Plan. We have to do the things that are really going to make the most difference. So that is both for us here, and I think you're doing that. You're concentrating on the things that are going to make the difference, but also making sure that we don't, we're not forced to feed a beast that's the national and the ICS. And again, we help them to narrow down onto the things that are going to be helpful to the front line, because otherwise this just grows and grows and grows, and it takes our eye off the ball and things. But you're doing a really good job on keeping us focused on the priorities. So thank you.
No, very well said, Jane. And just to reiterate, Jeffrey, you need to help us help you. If you need head cover, just ask for it and you'll get it. So questions and perspectives, keeping the pace going. Andrew?
Yeah, I was going to ask this in Glenn's paper, but save it for now. Really, I think filling our establishment is probably the most challenging objective we've got. And Glenn mentioned, the needs to make sure we make proper decisions around developments based on the costs of staff. I think that should actually be on our ability to recruit certain staff. There's a limiting factor there. But my question really, and again, it linked partly to a comment Glenn made in his paper, was what's the role of the ICS in this? You referred to it in your paper, Jeffrey, and I think there's both a workforce role and a service role in limiting the staff that we need. And how does that interface with the role of the foundation group, which provides a source of innovation and good practice, and making sure they don't overlap? Does that make sense, the question?
I think so. We'll see if Glenn answers it. I'll take this monkey off your back straight away, Jeffrey. Glenn, over to you. You've got the monkey.
Yeah, I'll try and answer it. I think it's a really good question, and within that question is part of the kind of dilemma about how we ensure that integrated care systems add value to what we're doing as individual organisations. So I suppose what I would say at ICS level, there's an opportunity to add scale to some things and consistency to some things. Otherwise, we could end up all fishing in the same pool of staff. So what we jointly want to ensure is that we increase the total workforce in the health and care system. And obviously then at ICS level, it also goes beyond health, doesn't it, into care particularly and other partners. So the ability to think about roles that are broader than just individual organisations, that are more system roles. So I think there's all of that can be done. I've got a bit of an issue about the way that the NHS recruits as well, and I think that was beautifully highlighted by Christabel earlier. Looking on the website and finding whether that we've got this bit of job or that bit of job. We should be recruiting to the NHS, and it's the way my brother's in the army. It's the way the army does it. They recruit to the army. They're not worried about the regiment. It's come and join us. This is a career for you in health and care. So I think we can learn from that. But at organisational level, you can't dodge the accountability of trying to ensure that we deliver and look after our staff. And I think particularly the role of line management in all of that, our approach to staff well-being, is something that we need to own and not expect anyone else to pick up and do on our behalf. So that's really important. And then I suppose you add the group dynamic to that. And the group is all about sharing best practice, and Jeffrey and Gertie, whose people lead in Swift and George Eliot, has they share a lot of things that they're doing together. We saw a bit more of that this week in Group Strategy Committee about learning and development. We've got a leadership programme that spans the group because there's a bit of scale associated with that. And so I think I can articulate how it fits together. But what we've got to avoid is a bit of a mentality creeping in from colleagues at NHS England, and I will tell them this when I speak with them, that the integrated care system needs to have a people strategy and a this strategy and a that strategy. No, it doesn't. It needs to be adding value to what we're doing and thinking about the space it can fill, that only it can do to add to that. And there's lots that only it can do with that partnership in the room. So that's and just to completely agree with your statement, filling our vacancies is the most important task. Although in that task, we also need to think about whether the jobs are the right jobs, and whether that's the problem in itself, that we need to be changing the shape of our workforce and finding it easier to recruit as a consequence. I don't know if that answers the question, but there's a few of my points. A really good question.
Thanks, Glenn. Jeffrey, is there anything you wanted to add to that?
No, really. I think Glenn has really covered the question very comprehensively. I would say that from my perspective, though, so far, the ICS are trying to work with us in a collaborative partnership approach in terms of the whole recruitment and retention side of things. The new Chief People Officer for the ICS, we're having some really good conversations currently. She's been in post about 3-4 months now, so still fairly early days. But from what I can see so far, I think it's got potential for her to be a partner with us to try and address some of the challenges we have. So far, it's working okay so far.
Yeah, as Ian said, the ICS needs to add value, not duplicate. And Frank, you're on mute, mate.
Sorry, Nicola, Ian and I see the activity report in Jeffrey's department, and it surprised me to see some of the numbers. And I just wonder, are we assured that Jeffrey's getting sufficient resources? Do they benchmark well?
So Jeffrey, do you think you need more resources?
I think we could all do.
I
think we could all do with more, but we got to be realistic as well. But I would say that's why I mentioned the pilot we're going to be doing with this national pilot and the whole recruitment department. So hopefully, if we can do that piece of work over the next 6 months, the intention behind that is to look at your structures, look at your protocols, and then try and come up with recommendations on what you can do differently. So I would say we got to do some more work on that, and I'll feed back to the board in due course.
Okay, great, thank you. Really conscious of time now, guys, but Nicola?
Yeah, no, I just put something in the chat, but for me, you know, Jeffrey set a brilliant framework of where we need to work, and he's now following that up. But I think the success in this lies that if you have a gap in your team and you are the manager of that team, you lead that team, it becomes your responsibility and to help gap it. And I do wonder, and on some of my visits chatting, how much is that gap seen as somebody up there's problem and not just my problem of filling a member of my team? And I think that's something that I think we probably need to do a little bit better to share the load of filling some of those gaps.
I agree, Nicola, and that goes, I think, to some of the cultural points that Jane was making this morning's session on productivity as well. So I can see Jane nodding. Okay, Jeffrey, remember, just focus on the key operational deliveries, and we're there to help you. So seek help when you need it, my friend. We'll move on then to and we need to pick up the time bit, guys. The staffing report. Emma, anything you particularly like to put out?
Just to say really that staffing remains a challenge, as we've heard throughout today's meeting. Fill rates are improving, but that has had a financial consequence as well. We're really having a focus in relation to how we can improve staffing within nursing, and we've got some very clear work streams. So the first of those is our HCA workforce, looking at retention and recruitment, and just pulling back to what Glenn asked earlier about volumes of agency band twos. We've been really trying to reduce that down, and at the end of July we actually had 6.8 whole-time equivalent agency and 9.7 bank. At the end of August that was down to 0.97 agency and 9.21 bank. So it just shows sort of the improvements that have been made on month, really trying to challenge when we need to utilise agency band twos or not. Other areas we're working on, we've just undertaken acuity and dependency reviews, which will be feeding back to Lucy on her return across our ward areas, and we're now looking at specialist areas throughout October. We are also doing some comparative analysis with our colleagues Swift, George Eliot and Worcester regarding our staffing levels and our care hours per patient day. We are looking at reviewing our agency rates. There's a paper to come later on today looking at that, and also on new contract proposals for agency. Big focus on our RMN usage, which again we heard about earlier, and also we've got a new escalation process in place for approval for high cost agency as well. So it was just really to update people on the work that we're currently undertaking, really striving to bring that agency costs down.
Thank you, Emma. Any questions or perspectives to Emma on the safe staffing report? Obviously tough. Thank you for your summary. Okay, team, moving on then to the policy panel update. Erica, do you just want to take as read, or anything you'd like to put out?
I'll take as read, Chairman.
Any questions on the policy panel update? Okay, thank you, Erica. And then the board assurance framework and high risks. Back again with you, Erica.
I think, Chair, it reflects fully the discussion in the board and the integrated performance reports. I'll just draw your attention to there's a new BAF risk, which is 1605, relating to capital funds not being sufficient to meet the collective requirements of the trust, and a new high risk that the board won't have seen, 1592, relating to geriatric medical staffing. But other than that, it's as has been presented to the board previously.
Yeah, very red. Questions or perspectives to Erica on the BAF for the high risks? Okay, thank you, Erica. I know there's always a bucket load of work that goes on behind those slides, so thank you everyone who's involved in it. The Health, Safety and Wellbeing Annual Report. Again, Erica, back with you. Anything you particularly like to pull out?
We have had the focus of the Health and Safety Executive during the time of the report, and I think we were able to provide solid evidence and quick decisive action. And I think that's testament to a continually improving health and safety culture, and that we see that in the Health, Safety and Wellbeing Committee. We have got our eye on our strategic priorities, which are we are seeing a slight rising trend in violence and aggression towards staff and incidents of sharps, but the work of the committee continues to address those.
Okay, thank you, Erica. Any questions or perspectives to Erica on the Health, Safety and Wellbeing Annual Report? Okay, thank you. So we'll move on then to committee summary reports, the first of which is the Integrated Care Executive, the 8th of August. Francis, over to you.
Thank you very much. Take the paper as read. I think the important point that I'd like colleagues to note is the rigour under which we are making sure that contracts that are delegated to place through Y-Valley as a lead provider are robust, and some helpful work on due diligence supported by Katie and Erica and others, so that we can be confident that as we assume responsibility on behalf of the system with our partners for services moving forward, that we're doing that in a robust way, and that with Katie, John and others looking at the process for assurance and scrutiny that will enable partners to relinquish the duplication, which has been, as you know, one of the overriding principles, that we don't look at things in two places. Very helpful discussions with Hilary Hall, the new Director of Adults and Communities, and with colleagues in the Mental Health Trust and with general practice, so that we can assume responsibilities on behalf of the system. So we've touched on things earlier, haven't we, about the importance of joined up care around care homes and those principles, and that is absolutely driving the work that we deliver through the Integrated Care Executive. But happy to take any questions.
Thanks, Francis. I think David is on the line. The Integrated Care Executive in Herefordshire is a really interesting development, if you like, of how we, and I think it was designed by Jane and others, how we ensure that we do work effectively at place with partners, and Francis is the chair of that Integrated Care Executive. Any questions to Francis on her update? Okay, thank you, Francis. Please continue to keep us briefed. So we're then on to the Quality Committee of the 30th of June and the 28th of July. Chris, what would you like to put out?
On the 30th of June, it's really to refer back to this issue with completion of initial health assessments for children in care. The committee continues to be concerned at the delays that prevail with these situations, partly due to staffing, but partly due to the increased numbers. And we've asked for this to be escalated to ICB level, because it's a system-wide issue, but I wanted the board to be specifically cited on that, so thank you for that. I don't think there was anything other, except there was a typo in the second report in the safeguarding bit, but that's sorry about that, swan song. But otherwise, no, take as read. Thank you, Chair.
Okay, great. Thanks, Chris. Any questions to Chris on that? Ian will obviously keep us briefed on that specific issue as that develops. Okay, team. So I think we are then on to any other business. Any other business, colleagues? Please raise a digital hand. Now, I know you'll be excited, but we do now have a question from the member of the public. Chris, bless him, has sent in an email. For those of us who remember, Chris was wonderful at sort of asking very specific questions, and he sent a nice email to Glenn and I, at the end of which was a question. So, Erica, do you want to read that question out for me, please?
The question was, nationally, some NHS trusts have been using repayment clauses in contracts for international healthcare workers. Members of the Commons Health and Social Care Committee have said the use of repayment clauses was part of a wider picture of worsening exploitation of international workers. Can you please clarify the situation at WVT with regard to repayment clauses?
Jeffrey, I think you're going to answer this, but in your answer, could you just explain what a repayment clause is in this context?
Well, thanks, Chair. Well, a repayment clause basically is a clause that organizations use whereby they provide some financial support to new employees joining the organization on the understanding that were they to leave within a given period of time, they'll have to repay back some of that financial support on a sliding scale, depending on how long they've been with the organization for. So that's basically a repayment clause. In terms of from a Y Valley perspective, Y Valley and many other organizations within the health service do incur significant amount of costs in bringing over international staff. And so what we do is we use a repayment clause, which is very clear to the individuals that if they were to leave us within a period of time, i.e. within 36 months, they will then have to repay back a proportion of that money that we've put forward to get the individuals over on a sliding scale. And I must say that over the last few years, we haven't had that yet within Y Valley. But it's something that we use not just for overseas staff, we also use that for UK-based staff, because we also provide relocation allowances, for instance. And if you have that financial support from the trust, then that's on the understanding that you would stay with us for a period of time, and were you to leave, then based on how long you've been with us for, you would have to repay back a proportion of the money received from the outset. So not just for international staff, but also for UK-based individuals as well who receive this financial support from the organisation.
Okay, that's helpful, Jeffrey, and is, I think, quite assuring. And I can understand the appropriate financial balance given the support we give. The key concern for me would be if there were any sort of undertones of racism by us treating international staff differently from the way we would treat British nationals or people who come from Britain. But your last point, I think, is helpful clarification on that. Any questions or perspectives on Jeffrey's answer? Okay, team. Well, like I said, this is Chris and Richard's last public board with us. You leave with our love. I'm sure Richard would continue to use that background at every possible opportunity, even after he leaves us. But you leave with our love and best wishes and enormous thanks. To executive colleagues, we'll get together in 15 minutes. We'll have a quick comfort break. Can we just stop the recording of the meeting for a minute? It's just one more thing I want